Hello. So this is another article for the college that I was have to read and do like a summary thoughts thing on. It's quite long, so I won't be reading the whole thing. It's ooh, titled "The Impact of Addiction Medications on Treatment Outcomes for Persons with Co-occurring PTSD and Opioid Use Disorder." This was printed in the American Journal on Addictions in 2015. Um, so, backgrounds and objectives. Previous research has been inclusive about whether adding psychosocial treatment to medication-assisted treatment improves outcomes for patients with co-occurring psychiatric and opioid use disorder. This study evaluated the impact of MAT, which is medication-assisted treatment, and psychosocial therapies on treatment outcomes for patients with co-occurring opioid use and PTSD. Patients meeting criteria for PTSD and substance use disorders were randomly assigned to one of the three treatment conditions: standard care alone, integrated cognitive behavioral therapy plus standard care, or individual addiction counseling plus standard care. Substance use and psychiatric symptoms were assessed at baseline and 6 months. Okay, Only patients with opioid use disorders were included in the present analysis, though. Two ways, ANOVAS, and logistics regression analysis were used to examine the associations between treatment conditions and MAT for substance abuse use and psychiatric outcomes. So results. Medication-assisted treatment patients receiving cognitive behavioral therapy plus, no, not that one, individual addiction counseling. No, I was right the first time. Okay, because this is ICBT, so that's integrated cognitive behavioral therapy, has significantly decreased odds of a positive urine drug screening compared to the non-medical assisted treatment patients receiving standard care alone. For PTSD symptoms, a significant conclusion and scientific significance for patients with co-occurring opioid use disorders and PTSD, MAT plus ICBT is associated with more significant improvement in substance use. ICBT is also more beneficial for PTSD symptoms. So, an estimate of 2.5 million Americans meet criteria for opioid use disorders. Medication-assisted treatments, including methadone, bupropion, naloxone, and FDA-approved medications for the treatment of opioid addiction. Compared to psychosocial treatment only, Compared to psychosocial treatment only, MAT is associated with improved retention and decreased relapse rates. Unfortunately, co-occurring psychiatric disorders are highly prevalent among patients with opioid use disorders. Over 1/3 of treatment-seeking patients with OUDs also have a current psychiatric disorder. Without targeted treatment for their psychiatric symptoms, patients with co-occurring opioid use and psychiatric disorders have a higher rate of continued substance use, um, and overdose, poorly occupational functioning, and decreased quality of life. And as case managers and professional helpers, um, it's really what we're assisting with is we're assisting our clients get a higher quality of life. So this is highly important. Even if you're not directly working with the substance abuse field, it's so adamant in today's world that having this knowledge can only help you. Although MAT is considered efficacious for treating opioid dependency, the impact of co-occurring psychiatric disorders on treatment outcomes is equivocal. MAT patients with co-occurring disorders have more severe psychiatric, medical, and legal problems at intake and post-treatment, and are at higher risk of relapse and treatment in non-compliance. So that's kind of the introduction piece to this article. And then methods. It goes on to a secondary analysis was conducted using data obtained from an RCT of integrated psychosocial treatment. Adult patients entering treatment at 7 community addiction treatment agencies were screened at intake for PTSD using the PTSD checklist. Consenting patients scoring 44 or above on the PCLC completed a baseline study assessment. Those meeting diagnostic criteria for PTSD were randomized to one of the 3 treatment conditions mentioned before. Assignments were conducted at baseline and 6 months. Study design, maintenance, and consent procedures were all monitored and approved by the trustees of Dartmouth College Committee for the Protection of Human Subjects. All research was conducted in accordance with human subjects protections. Whew. So, they did that. They put them into one of the 3 categories, as mentioned before, for treatment, which were standard care alone, integrated cognitive behavioral therapy plus standard care, or individual addiction counseling plus standard care. So I'm going to show. They have a lot of graphs. This has a lot of graphs to show. It's to show who people reading it, what exactly they're seeing. There's 4 great pages of just graph between the demographics, the substance use, psychiatric and PTSD. That's table 1. And they also have it continued on prescription medications and what people did. And then they continue to the substance use outcomes, the PTSD outcomes, and treatment utilization under the category of results. So, baseline demographics, substance use, and psychiatric characteristics of patients are shown in Table 1. The majority of patients were female and Caucasian. Most met criteria for multiple substance use disorders. 51% of participants, 51, which is 40% of the participants, had been in a residential program for substance use in a month prior to baseline. The average score was in the severe range of being less than 65. Besides PTSD, patients met criteria for 3.71 current psychiatric disorders on average, most commonly mood and anxiety disorders. Only patients met criteria for current, only 9.252 patients met criteria for current PTSD only. So this means, because as I mentioned before, they all had PTSD, but only 9% of them had current met criteria PTSD only. Most of them met criteria in several different ways. So, approximately 72% of the patients were prescribed psychotropic medications. So during the 6-month follow-up period, bupropion was the most common medication prescribed, followed by methadone. Now they're talking about like dosage that people were prescribed. Okay, then we have a substance use outcomes, and then another table that's titled the impact of addiction medication on co-occurring disorders. So across the entire sample, there was no overall decrease in the rate of positive urine drug screens from baseline to 6 months. Wow. MAT patients in the ICBT treatment condition had a 93 decrease in the odds of a positive drug screen. This seems to reaffirm the video I watched, where you have to kind of treat both the substance abuse, the substance use disorder, and the mental health condition. Because if you just treat one, then the other one is not being addressed. Though sometimes the cause of one. So like if you treat the PTSD might be the thing that's causing the substance abuse. So, but the best course of treatment is to treat both. All right. And then in chart 2, they have the changes in substance use and psychiatric system baseline. So that's all I have to say on that. So to sum up, they did a study on people with co-occurring PTSD and opioid use, and used 3 different treatments, categories them into 3 different treatments. Either standard care, integrated cognitive behavioral therapy, plus standard care, or individual addiction counseling, plus standard care. What they found is, across the entire sample, there was no overall decrease in the rate of positive urine drug screens from baseline to 6 months. Using a multivariate logistic model, we examined the odds of a positive drug screen at 6 months controlling for rates of baseline positive drug screens, age, gender, treatment site, and IV drug use. Medically assisted treatment patients in the ICBT treatment condition had a 93 decrease in the odds of positive drug screen. There was no significant difference in the odds of positive drug screen were detected when comparing all other treatment combinations with standard care plus no medical assisted treatment. So that's it. Thanks for watching. So, I had a goodbye message in some of my other videos. I ended up accidentally deleting it. I just want to take a moment to say thank you for everyone who's watched. I personally have been making these videos for me, and doing them has kept me accountable, and I've learned so much. So if you like these, please like, subscribe, leave me a comment telling me what you want me to do, really. I admit the coping skills ones are a little bit more for fun than for information. But I came up with this idea because of the COVID stuff going on in the world, and I realized now is the time to start taking better care of myself. Not enough people do, surprisingly, not surprisingly. But with having no classes, no job, no nothing, just sitting around, and that wasn't me. I needed something to do. So I still am taking classes right now, but I've also found myself, this why I started these videos, taking care of myself in all 8 dimensions of wellness. But yeah, so if you like it, well, thank you. Subscribe, like, the spiel. Thanks for watching.